Okay. Bon, why don't we get started? It's 12:05. Alors, bonjour à tous, bienvenue à la série Scientifique. It's a pleasure for me to introduce Dr. Rick Ma, who is a key figure and a member of St. Mary's community for many years now. Dr. Ma a complété sa formation médicale à l'Université d'Alberta. Par la suite, il a complété sa résidence en médecine familiale ici à McGill. He obtained his bachelor's in biomedical informatics from the Oregon Health and Science University in 2021. And he did something very altruistic, which is to be the head of the ER at St. Mary's and Sears during the pandemic era. So for that, we are very grateful. On est très reconnaissant. Dr. Ma's research interests include geriatric emergency medicine, quality improvement, and operation within the ER. Donc, le titre de la présentation aujourd'hui, Trajectories of Frequent Short-Term Emergency Department Visits Among Older Adults, les trajectoires de séjours fréquents et court terme à l'urgence auprès des patients âgés. Dr. Ma, thank you for joining us.
Everybody, and thank you for that rapid translation of my presentation. So I don't actually have, I'm not actually able to see the chat. So if there's anything that comes up, just let me know.
At the end,
At the end?
screen with all
All the questions and stuff. Okay, sounds good. I have to say that one little funny story is that last night, or actually on Sunday night, I was actually in the emergency department in the evening, and it was like about 9 o'clock, and I was going to the doctor's office, and our doctor's office is kind of really in the back part, with maintenance and everything, and I'm walking by, and there's a fellow that's coming towards me, and he's in housekeeping, and I kind of recognize him. And I say, "Hey, how's it going?" He goes, "Good, good." He walks by and then he stops and he goes, "You're giving a talk?" Yeah, I am giving a talk. Well, good luck with that. And he just kind of kept walking. I think that's what I love about St. Mary's, so that's really good. Okay, so let's get started. So this is my long-winded title of my topic today. I have no conflicts of interest to declare, but I do have a disclaimer that I am a statistical nerd, so I don't know a lot about statistics. So I'm really glad that Eric is here because if there's questions regarding the statistical part of it, he can maybe help me out. The objectives of my talk are really to talk about a relatively understudied population that comes to the emergency department. And to introduce group-based trajectory modeling as a potential methodology that might be useful in all sorts of other projects. I don't know, has anybody used group-based trajectory modeling or no?
Heard of it.
Heard of it? Okay, perfect. It's like that's my level too. So we're going to talk a little bit about that, and then also to sort of look at some of the potential opportunities for research or clinical intervention based on the work that we did. This actually originated as a care project, which I'm very grateful to Jane and Denise, Julia, Antonio, and David Dorr, who is my capstone supervisor for my master's. And of course, I put hardest working guy, which is Eric, who has really held my hand for the last 5 years. So thank you, Eric. And I've learned a lot, but still there's too much more to learn. So I really appreciate all that support. And also thank you to the Research Center. Without all the support from Research Center, this project would not have sort of gained any traction or come to this point. Particularly, I also want to thank Manon, who's also been the other person who's held my hand, who's like helped me with all the posters and all the presentations and all the various redactions and stuff. So thank you. And also the foundation, because without the foundation support, this really wouldn't be happening today. So just as a quick summary as to emergency departments and the use of other emergency departments by older adults, it's a very important population for us. In 2003, it accounted for about 17.3% of visits. That increased to 24% in 2021, and it's actually expected to increase, just given the changing demographic of Canada right now. Older adults, they represent a sort of a special population for us also in terms of risk, because older adults presenting to the ER often require admission or die. Or if they're discharged, they're very likely to come back to the emergency department, require admission, and subsequently die. So they're a high-risk population that we have to be very careful with and to be very diligent. The other issue, though, is that older adults also tend to become frequent users of the emergency. And that's sort of more so than the general adult population, accounting for, in one study, up to 30% of emergency department visits. And these frequent visits, these patients who have frequent visits, they also often will tend to have more risk of being admitted, having longer inpatient length of stay, and also increased mortality. So it's a population that is really important, and they're significant drivers for the healthcare system. Just going to let Chris take that picture. Okay, so in fact, the origins of this project really started with a clinical observation, and typically what happens in the emergency department is that at shift change, we're doing what's called a sign over. So it's about 15 or 20 minutes of transferring the patients to our incoming colleague. And often it's a really short capsule summary of the patient, like, bed 8, Mr. So-and-so has this, and this is the plan. But one of the common phrases that we hear is, well, Mr. X, right? Like, he's here all the time. And sometimes it's sort of this uncomfortable, it's like, yeah, I know, yeah, no, I don't know him. So in fact, what happens is that what we see is that some of the frequent users of the emergency department, we actually don't know that they're actually frequent users even, partly because of the fact that we work in the emergency department, we work shift work, we're not there every day. We don't necessarily know that they're frequent users or frequent visitors. Also, the patients may have some cognitive impairment, or they may not have family with them, and so they may not be able to even tell us that they have actually been to the emergency frequently, or they've been to another emergency frequently. And this little fact that the patient has come to the emergency frequently is actually it impacts sort of clinical decision making, because typically, if you have a patient who is coming frequently, the question that always comes up is what are we missing? Because often frequent visits are either related to either an expected or unexpected evolution of the condition, meaning they have a pneumonia and they got sick and they were required to come back because they got worse, or that we may have missed something. Or the other possibility is that there's just an unmet need that we just have not completely addressed or have not satisfactorily addressed. And some of those needs are actually unresolvable from the perspective of the emergency department. Say, for instance, homelessness. So whenever we have patients who come frequently to our emergency department, the question is always, what are we missing? And then the other question that really comes up, and it's really like high on our list, is, okay, if I'm going to discharge Mr. X, am I going to be able to discharge him safely from the emergency department, or is something bad going to happen? And so that's sort of always the question. And the data is not that useful in terms of why patients come in, particularly within the older adult population, because we know with the general adult population, meaning less than 65, is that often the most common causes are substance use disorders, mental health disorders, marginalization, or lack of access to care. But for older adults, it's not really quite that clear. It really doesn't seem related that much or as much to substance use disorder or mental health disorder, but more along the lines of either minor issues that require a few more visits to resolve, or chronic illness, whether it's heart or lung problems or cancer or cognitive impairment or frailty. But we don't really know, like it's really kind of two separate populations that we're talking about. We're talking about frequent users. And within the literature, it's actually, there's a few limitations, because a lot of the literature defines frequent use as 4 visits within a year. And I'll explain to you in a little bit as to why that's a little bit problematic. And there's also different methodologies that have been used to sort of do this type of research. And they also have their limitations in terms of being clinically relevant for the emergency doctor. So typically the research projects will often start with an index visit, and sometimes it's sort of sequential patients that come to the emergency department, and then they're followed out for a year. Or sometimes they may be just sort of either randomly selected, and then they're looked for, and you look forward for a year. And that's how you define your population. And then various variables and factors we look for those factors to explain why were they frequent visitors for that year. But the question that always kind of puzzled me was, well, kind of what happens in the back end? Like what happens before that first index visit? Um, have they had one visit, or have they had three visits? Or what if they had three visits really close together? Like, does that make a difference? And that's a question that is always kind of on my mind in the emergency department, because we see patients that will come very frequently in a very highly concentrated time. And what does that mean? Like, is that patient more at risk or not? And so that's kind of the origins of this project. The other sort of technique that has been done is that they've looked at other research projects that have looked at an index visit. They've gone back a year to identify those frequent users, and then they've actually looked forward to see what's happened to them. And the one difficulty with that is that 1 year looking forward is a little bit hard for me to sort of make any call when I'm at the bedside, because as to what happens in a year, like lots of things could happen in a year, and there's not necessarily any causality that's going to result from my visit and my decision to send the patient home a year down the road. It's too far. Whoops. So what we sort of decided, sort of conceptualized, was that we were going to do a project where we actually looked at patients that actually presented to emergency in a really high intensity, high frequency period. And then the next part of the study, which has not been complete yet, is actually to look at what happens to the patients 90 days after that index visit. And this also reflects a reality that we see, is that we do see patients that come that we've never seen before, we've never seen their names before, they've never appeared, and all of a sudden they start appearing in the emergency department. And then why is that? What's going on? And this is the reason that we wanted to capture this population. On top of it, the other question was, does the pattern of use actually make any difference? And is this particular pattern with this revisit spread out over 90 days? Is that any different from what happens if they come in like really tightly together, bunched up before the index visit? And so with that, so that was a question that I kind of raised, and Eric proposed using group-based trajectory modeling, which I'd never heard of before, and it's pretty cool. So group-based trajectory modeling is a tool which identifies groups of patients with similar behavior of evolution over time. It doesn't presume that there's specific subpopulations, though. It just sort of says that within this group of observations, that there's actually distinct trajectories within it. So there's groups that have certain trajectories, and you can sort of imagine if you're on a highway and you're looking at the highway, and you have the guy who's speeding, you have the person who's driving slow, you have the bus driver, you have the person who's driving a transport truck. So they all have different trajectories over time, but within that, you're just seeing the traffic. So what group-based trajectory modeling helps to do is it helps to kind of separate it, or introduces possible different trajectories. Beyond that, you can use statistical measures to sort of identify the shape of each curve. And also you can actually ask, well, what if there's two trajectories? What if there's three? What if there's four? What if there's five? And then there's statistical methods to sort of decide which model seems to fit the data the best. And then there's further criteria to sort of further hone in to see whether or not the model actually works or not. And so it's really an iterative process. And in fact, what happens is at the end, you can have a couple of options, and you need to sort of evaluate whether or not it actually makes any face validity, if it actually makes sense or not. And that's sort of really the final sort of test for this type of modeling. So just to kind of give an example then, so this is one project which looked at actually cholesterol lowering agent prescriptions, and followed the compliance over a 15-month period. And they used group-based trajectory modeling to sort of try to look at, okay, how are patients using it, and are there different ways that patients are using it? And then looking at any covariates that might be associated with those trajectories. So you can see, you can sort of look at this in terms of, okay, you can say, I want two trajectories, and this is what you get. Or you get 3, 4, or 5 trajectories. And so what's interesting is that you sort of see that it's not necessarily people are given prescriptions and they take the prescription, or people take the prescription and they toss the prescription. There's actually a whole mix sort of in the middle where, I'm not sure if my mouse works, where you'll see that some people will actually kind of gradually kind of go down with their compliance, where other people will go down and then all of a sudden, for some reason, they actually pick up and they start becoming more compliant, or some people that just level off. And so with group-based trajectory modeling, it will generate all these different trajectories, and then you test it. And then you test it to see whether or not which is the one that sort of most accurately represents the population that you're studying, with various statistical tests and then face validity. The kind of the annoying thing for this particular author was that, in fact, it was the sixth model, the sixth trajectory model that was the best, and they forgot to put it in the paper. Anyway, so I don't know what the answer is, but you can sort of see that there's potential for looking at different trajectories and sort of saying, okay, well, like what can I do to sort of improve compliance, and then you have different strategies based on the different trajectory that they might exhibit. Another one is actually using the group-based trajectory modeling to look at prognostication. And so here what they did was they actually looked at the trajectories based on the EEG findings over the initial 36 hours after cardiac arrest. And then they studied the different groups based on that. And so here it was their trajectory model that they used. And in fact, what it shows is that on the y-axis here is you have the suppression ratio. And what that means is that the higher the number, the more inactive the brain is. So the more the more severe the insult is. And then on the horizontal axis is you have the time. And so just for example, so if you look at 0.6 here, you'll see that there's actually 2 trajectories that are starting from there, but they have very different responses and outcomes. And so the orange line, they don't do as well, but the green one actually does start to improve quite a bit. And so these are potentially very powerful tools that we can use in terms of talking about prognosis, and very useful when we're having that discussion with patients. So that's kind of what kind of gets me excited about group-based trajectory modeling, because it has this potential to try to explain different things. So our sort of study then was to look at the population. So we looked actually at the population of Quebec, all patients over the age of 65, and we used administrative databases from RAMQ and the ministry. And we basically looked at an index case in an 18-month period between July 2014 to December 2015. And our population of interest was 3 patients who had 3 or more visits in the 90 days prior to that index visit. So you could sort of say that after those 90 days, they had actually had 4 visits. So they were, by definition, frequent users. And then we used group-based trajectory modeling to sort of look at trajectories, and then also to look at the variables associated with those patients to see if we could actually describe the trajectories in the patients that belong to those trajectories. So the available variables that we had were these. So we had basically age and gender. The ones that are kind of in a slightly kind of faded gray are the ones that we either didn't have access to, so we didn't really have place of residence, which would have been useful, and we had no information on past medical history. We knew the hospital that they presented to, and from that we knew actually the type of hospital, so whether it was a rural hospital, urban hospital, what's called a primary emergency, which is a very small emergency, all the way to tertiary care. We also knew that based on what their CTAS code was, which is their triage score. And so a 1 meaning basically a very sick patient requiring immediate resuscitation versus 5, which was considered more of a minor complaint. We had the arrival mode. We actually also were very lucky because with the data that we have to present to the ministry on a monthly basis, we know exactly what the complaint is as well. So we know each patient's complaint. We know whether they ended up on a stretcher or were sent to the waiting room after triage, the number and type of consultations, their length of stay, and their final diagnosis. So our derivation then was basically starting with a total of 547 and change thousand visits, for which we removed 20,000, which were visits that were basically visits to the equivalent of a CLSC walk-in. So we took those out because those weren't really emergency department visits, because these dispensaries weren't able to admit patients. So we removed those. We're left with over 500,000 visits in that 18-month period. And then we broke it down to looking at, okay, so if we go back, how many visits did they have? Did they have any visits at all? And so 400,000 or so had no visits in the 90 days prior. And then 80,000 had one visit. Two visits, there's 22,000. And then for our population we wanted to study was actually 10,000 patients that actually had three or more visits. Not a huge number, but in the context, it still represents 2.1% of the population that we are studying, but they accounted for 7.5% of all ED visits. So not a big group, but a substantial impact on the emergency department. So I'm going to be showing a bunch of these slides. So if just let me know if you need me to stop and explain, because like I've tried to explain this a million times. I think Eric has explained it to me too. So I'm going to try to explain it as best as I can. So this is just like a general summary of our 10,000 patients and kind of what happened to them over the 90 days from the index. So on the y-axis is you have the probability that the patient is going to present to an emergency department for an emergency department visit. And then on the horizontal axis is time, which is minus 90 all the way to 0, which is the index. And this is just a summary of the probability of our population visiting the emergency on any particular given day up until the index. And then we broke it down to what the no admission cohort would look like, which is sort of a kind of fairly stable, but then all of a sudden increasing closer to the index. And then also the admission cohort, which sort of mirrored the same thing, but not to the same extent. This isn't group-based trajectory modeling. This is just more, we're just wanting to demonstrate sort of the cumulative behavior of our population. But when we do apply group-based trajectory modeling, so this is the no admission cohort. So what that means is that these are patients who, for all their visits before the index, were seen and discharged, or what we call treat and release. So they were well enough that they did not require admission. They were sent home, and then at some point they came back. And so this is the trajectory model that we eventually kind of settled on after much debate and discussion. And so in fact it's a three trajectory model. And so this first one, which is the dotted line, is what we call stable, because essentially the probability of emergency department visit is present the entire 90 days prior to the index. Whereas the solid line, which we call increasing, is actually a group that has essentially a zero chance of presenting to the emergency in the first 20 days or so, but then gradually starts to increase as they approach the index. And then we described a different population or different trajectory where it was very low risk of presenting to the emergency up until about 20 days before the index, and then it increased to the point where near the index is about a 6% probability that they're going to present to the ER. And that population we call hyperacute. For the admission cohort, what we did here, so basically to be in the admission cohort, you had to have at least one admission to the hospital. So in those 90 days, you went to the emergency department, and that emergency department led you to being admitted to the hospital. So our model was a two trajectory model, and I've kind of separated here just to sort of visualize it a bit better. And so we also found two trajectories, one we called stable, the one we called increasing. And so the stable is the dotted line here. And so that's actually just that there's a nearly constant probability that they were going to present to the emergency department. Whereas increasing the trajectory was it gradually increased over time. What's interesting though is that the two lines underneath, and what that is that's actually that we actually broke the type of emergency department visit down to the patient was seen in the emergency department and sent home, or the patient was seen in the emergency department and then admitted to hospital. Because for each ED visit for this population, there was the possibility of one of those two outcomes. And so the solid line here is actually means that the patients this was their ED visits without admission. So they were seen and they were released. And so you see that there's kind of a relatively stable probability throughout the 90 days that they would come to the emergency department and they would be sent home. Likewise, the dashed line is for the admission. The thing that I would point out here is that, so how I kind of look at this chart is that for this particular population, if they present to the emergency department, there's a 50% chance that they're going to be admitted. And that's pretty much along the entire 90-day period. Whereas the increasing group is a little bit different. So these patients ended up having a sort of a measurable probability of presenting to the emergency and being admitted throughout the 90 days. But what was different was that there's a period there where the patients did not present to the emergency department and have a no admission visit. So if these patients present to the emergency department in this sort of minus 90 to minus 60 period, there is almost 100% chance that these patients were admitted to hospital. So once we looked at the trajectories, then we tried to sort of look at some of those variables that I had mentioned previously to see whether or not any of them whether we could learn more about these trajectories. And the long story short is that the hyperacute trajectory, which is the one that sort of rises very quickly, was actually the most distinct with respect to their variables. They're less likely to have chronic illness. They're more likely to have a shorter length of stay, more likely to use a primary ED. And they also tended to use the same emergency department compared to stable and increasing. And what was a little bit disappointing for us was that the increasing and stable were actually very similar in terms of their patient characteristics. So we couldn't really distinguish based on the patient factors that we had. Of interest, though, is that the hyperacute, because we also looked at diagnoses. Was there a diagnosis or a system complaint? Meaning, was it lung? Was it heart? Was it skin? Was it rheumatologic? Was there some sort of diagnosis that was actually helped to sort of give us an idea to describe some of these trajectories? And the one thing that came up was that the 36% of patients in the hyperacute had at least one visit for cellulitis, which is a skin infection. So one could surmise that these patients had been diagnosed with a cellulitis, deemed that they would require intravenous antibiotic, and so they came back repeatedly to get their intravenous antibiotic. So that would be one population that could explain this type of trajectory. Compared to hyperacute, the increasing and stable trajectories tended to have a little bit more. Their discharge diagnoses were more sort of related to chronic illnesses like chronic lung disease, or they would be complaints that actually required a bit more, you can infer would require more investigation. So if a patient presented with chest pain, you'd have to do blood work, chest x-ray, ECGs, and so they would require more extensive workup. And then between stable and increasing, so stable was actually more likely to have visits for anemia, fluid overload, COPD, and syncope, and increasing was more likely to have their discharge diagnosis follow-up exams, which I'll explain in a little bit later. For admission, so this is the admission group. So in fact, stable and increasing, again, we weren't able to sort of distinguish any significant differences between the variables that we had. So they're actually quite similar. With respect to the admission diagnoses, which we're looking specifically to see what actually led these patients to be admitted to hospital. The diagnoses that were most common were COPD or chronic lung disease, anemia, urinary tract infections, and fever. And the visits that did not result in a hospital admission, meaning they were seen and discharged, it was actually cellulitis was more likely in the increasing group than in the stable. We had a number of limitations to our project, and one of it was and that's actually been kind of the major criticism when we went to publish, was the age of the data. because it was hard to sort of, well, it was a bit challenging to get the data, and in fact, we waited many months, if not years, for some of the other data requested. It was deemed that the data was maybe too old and maybe did not represent the current state of affairs. Although I would sort of argue that maybe the current state of affairs is actually worse than it was in 2014, but it's beside the point. The other thing is that we didn't actually have information on the inpatient length of stay. And you can see where that would actually affect our admission group, because if we didn't know because the patient is admitted, they can't come back to the emergency department. And so in fact, there's a little bit of a variation because of that, but in fact, the general curve and general shape of the trajectories remains unchanged. There are missing variables. I think knowing sort of things about chronic illness, frailty, where the patients lived would have been helpful and might actually have helped to sort of distinguish sort of membership in one trajectory or the other. And the quality of the data, like we're dealing with administrative data. So it's not, although there was not a lot of missed data. The thing is, you had to question a bit about the quality of the data, because often it would be the emergency department doctor who is kind of fed up and just wanting to enter a discharge diagnosis, or it might be the clerk who's entering the discharge diagnosis and can't read the doctor's writing. So there's all sorts of possibilities where the data, we couldn't really look too deeply into it, because the thing is that because of that variability. So in conclusion, group-based trajectory modeling can describe short-term high-intensity use in older adults in terms of trajectories, namely stable, increasing, and hyperacute. The other thing that was also interesting is that nearly half of our study population never reached the threshold of requiring admission. So when we had the no admission and admission group, well, they're actually split almost equally. So there's a 50% of our frequent users in our group did not actually have to be admitted for the 90 days, but they came to the emergency department and were subsequently released. And while there are statistically significant differences in some of the variables, we weren't really able to sort of say we couldn't really sort of define one to the other based on the variables, whether they belong to the stable or increasing trajectory. What do I think is going on? Is that I think that the stable group is a group of patients that they have this constant probability of presenting to the emergency department, which means that they may be a little bit sicker. They might have a bit more severe chronic disease, and or they might have limited access to healthcare. And so I kind of suspect it might be a combination of those two that might be defining the stable population. Whereas increasing, that group is actually kind of interesting, because like there is a period of time where they do not seem to present to the emergency department, and then they start to present. So one of the possibilities is that they have an acute condition that needs that then requires a number of visits to resolve. And in fact, one of the things that we looked at was we actually looked at the pattern of the visits for the admission group. So one of the things we did was we looked at all the visits and we said, okay, what's the pattern? Is it admission, discharge, admission, and then index, or admission, and then admission, and then another admission? And in fact, what happens is that in the increasing group, the vast majority of them start with an admission, and then return back to the emergency department, and they're discharged subsequent. So it's like it's not completely resolved. Whatever they had that brought them in the first place has not been resolved, and they keep coming back to emerge. And then the hyperacute was kind of this group, which is for the most part pretty well and had some sort of acute issue, and it just had for some reason needs to be resolved in the emergency department. The other thing that was actually interesting, which we kind of found which was not really related to trajectories, was that in our database, as I mentioned, is that we actually know what the presenting complaint was for every patient. And one of the things that was interesting was that we found that return visit, which is actually one of the complaints that the nurses can actually enter, actually figured fairly significantly in our population. So return visit is basically returning for reassessment, probably maybe IV antibiotic, maybe some imaging, maybe consultation, and they accounted for 11% of all ED visits in our sample. So, that's like almost 6,000 visits. And that all trajectories had this sort of phenomena, and it ranged from basically 6.8 to almost 21%. The other thing that was interesting was that within the admission cohort, 34% of patients use more than one emergency department. And in some cases, they use 2 or 3 emergency departments. And what that sort of implies is it means that if we're trying to do research from a single institution, it actually becomes very challenging because we don't actually know necessarily what's happened before because we know that a third of patients have gone elsewhere. The other thing, which I kind of suspect is that it also is a reflection of how ambulances are distributed on the island of Montreal. And that would be a really interesting thing to look at because I think that that's kind of what we're experiencing in the emergency department is that we there's a whole sort of temporal effect where around there's 2 different periods. So around 3 in the afternoon and around 11 o'clock at night is when there's very few hospitals that are open anymore, and we get all the patients from Laval coming at those periods of time. And I think that it's probably as a result of the ambulance protocol, and this is actually reflected in how patients are in our trajectories. And that I'm sure is worse, I think. In terms of clinical implications, I think that clinical decision making, there's really not a heck of a lot that I can really take to my emergency shift at this point, except for the fact that it's actually, you could argue that it's relatively easy to identify these patients. If you know the data, you can actually identify what trajectory they are. Because the thing is, if they had an ER visit in the 60 to 90 days before, you know that they're in the stable group because no one else is showing up at that time. If their ER visits only start to increase at day 60 or so, then they're probably in the increasing group. And if they haven't shown up until 20 days before the index visit, they're probably in the hyperacute group. But the question is does that make a difference? And that's the purpose of our future study. In terms of systemic sort of interventions that we could maybe look at would be sort of, now that we know that there's a low risk group, which accounts for 50% of our population, it's actually a little bit reassuring if we could actually define them and find and sort of say, okay, these guys are low risk. That's actually kind of helpful. If we found a different place for patients who in the hyperacute group where they could actually seek medical care or have their intravenous antibiotic, that would also help. That would actually address that particular trajectory. And I think one of the diagnoses that factored quite heavily in all of our trajectories was actually chronic lung disease, and sort of better outpatient management of chronic lung disease could potentially reduce the number of visits to the ER. And then I think better access for imaging and consultation could potentially also reduce those visits because like keep in mind that we had 10% of those visits were returns. As a bit of a teaser, then what happens at the index? So we've been kind of working a little bit on the data, and in fact, if we look at the population of 10,000 as a whole, the one thing we did not look at in our study was actually what happens at the index, because we were actually interested in just what happened before the index. So in fact, we know that at index, the mortality rate is 0.8%. But within the different trajectories, and these are all just very preliminary, so take it with a grain of salt. But within those trajectories, the mortality rate at index is there's actually a 10-fold change. So it's 0.1 to 1.4 risk of death. Risk of admission is 33% over the group of 10,000. But in terms of the trajectories, it ranges from 13 to 49%. So there is some dispersal that you can sort of see that will kind of help to sort of guide us in terms of which patients are at potentially risk of bad things happening to them. And that's really the purpose of our project, because we're not only wanting to look at index, but we're looking 90 days out with the idea that if we're able to sort of maybe identify these patients, then that may actually help us to make a disposition decision, saying that, okay, this patient is at risk of having an adverse outcome in the next, I don't know, 15 days. So, we're going to discharge patient, but this patient needs to have rapid follow-up with the CLC or primary care or what have you. The other question too is whether or not patients remain frequent attenders. Because if my hypothesis that the increasing group is a group that is generally well, they have an acute issue, they get admitted, and then they should actually return back to a relatively good baseline, and so they should stop becoming frequent users. And so we'll also be able to get that answer as well, hopefully with our second project. And then also looking at other variables would also be helpful because, like as I mentioned, we didn't look at severity of disease or frailty or place of residence. And that would be useful if someone's up for it to look at that. That's it. Thanks.
Thank you very much. Un grand merci, Dr. Ma. We'll open it up to questions and see if I'm going to be able to arrêter. Is this it? Yes. Okay, perfect. Okay, so those of you who are on the Zoom, please